All right, well, I'd like to second what the previous speakers have said about what a great opportunity it is to come today and speak, and really appreciate all of you coming out on Sunday morning to hear about this. And like was just stated, I'm hoping to take a little bit more of a practical approach here. So why do we do this? And I think they laid the groundwork very well in trying to describe what is it that we're doing and why. I'm going to try to integrate those two things because I think understanding how this is actually done, practically speaking, is really dependent on understanding why it is that we're doing this. Maybe. There we go. So for my talk today, we're going to try to cover three things. We're going to try to identify the types of immunotherapy that are in use and in development for melanoma, kidney, and lung cancers. We're trying to review the rationale for these different kinds of immunotherapy and really discuss the practical aspects of these different types of treatments. So long and the short is, here's the answer. So I can sit down now, but we'll go through it in more detail. So the three types of treatments that I'm going to talk about are vaccine therapies, which are predominantly given as injections into the skin, just like your flu shot. Cytokine therapies, which were alluded to a little bit earlier, which can be given intravenously or by skin injection. And monoclonal antibody therapies, which are given as intravenous treatments. And again, understanding what these treatments do will really help you understand why it is we give them the way that we do. But I will just state, notice that these aren't oral treatments, okay? So if people come to clinic, they want to get a drug they can take at home, right? It's much more convenient to take your pill at home than to come and get your infusion. And again, we're going to discuss why that is. But long story short is that these are drugs that have biological properties. And so they predominantly are proteins or other sort of molecules that are naturally in your body. So if you were to put them in your mouth, they'd be a lot like your lunch. They would be degraded going through your digestive tract, okay? So what are the mechanisms of action for immunotherapy? And this has been discussed so far, but I'm going to go through it a little bit further. As we talked about, the tumor finds ways to hide inside your body. They find ways to get the immune system to sort of stop attacking it. And that's through that immunoediting approach that was just alluded to, in which the tumor will grow and parts of the tumors can be killed, stayed in equilibrium, and then start to grow. It can express factors that can sort of confuse the immune system into not recognizing that the tumor is not supposed to be there. And an example of that is PD-L1, which you're going to hear a lot about today. There are also a number of factors in the tumor itself that are parts of your own body that are acting abnormally that actually tell the immune system to stop attacking the tumor. And that goes to properties of autoimmunity, where you don't want your immune system normally being too active, otherwise it can cause a lot of side effects. And all of you probably know people who have rheumatoid arthritis or inflammatory bowel disease, and that's sort of the reverse of what we're trying to do here. Those people have too much immune system, and it has to do with some of these things being overactive. So what we need to do with immunotherapy is try to overcome these and basically try to wake up the immune system. And I just want to second that it's really important to understand that the drugs in immunotherapy are not the drug itself is not going after the cancer to try to kill it. These drugs are given to try to induce the patient's body to fight the cancer. So in the same way, the drugs we give predominantly aren't causing the side effects themselves. The immune system's response is what's causing the side effects. So the first of these we're going to talk about are vaccine therapies. So vaccines are biological preparations that attempt to improve the immunity after getting an immune response to go after a very specific antigen. And antigens were discussed a little bit earlier. We'll go over them again. Most vaccines that you've heard about are prophylactic vaccines, meaning you get them before you get sick. And the idea is you educate the immune system so that when it gets exposed to something, you don't get sick. You already have an immune response. And the influenza is a good example of that. But in cancer, vaccines are actually slightly different. When we're giving cancer vaccines, patients already have cancer, and that's actually quite different from the prophylactic vaccines that get given for infections and need to be understood differently. Vaccines have specific parts, and this is really just for your knowledge base as much as anything. They have the antigen that we're trying to get the immune system to look at. They have something called an adjuvant, which is basically part of the preparation that sort of tries to stimulate the immune system to notice it. And they have a stabilizing agent often which allows it to have a longer shelf life. This is sometimes more and less in cancer vaccines. So the way this works in reality is that in some preparations is that you give these antigens, which can be any kind, so part of the tumor, part of a virus, part of a peptide, Those dendritic cells get injected, when it gets injected into the body, the dendritic cells find it. They then go to the lymph nodes and tell the T cells who go after the tumor. And this picture is a schema of an attempt to try to take dendritic cells out of the patient, expose them in the lab, and then put them back into people, which is an approach that's in use in prostate cancer now with a drug called Sipuleucel-T. So this I thought was sort of a funny diagram I saw on the internet when I was researching pictures for this. So this is the state of your immune system when you're not actively mounting an immune response to the tumor. And you can see that the cells that are supposed to be educating your cancer-fighting elements of your immune system are all confused. They're like, what's going on? Because this guy's all happy and he's telling them, chill out. The helper T cells, he says, oh, this is fine, don't worry about it. And the guys that are supposed to be doing something about it, they're all hanging out and they're not sure. But after inducing with a vaccine, these guys realize that this guy's not supposed to be here now. They go and tell these guys, and they can then go fight the tumor. So, practical. How are vaccines given? So I said that predominantly they're injected in the skin. And that's because you want, once they're injected, for the dendritic cells to notice them, take them up, to then go show the rest of the immune system. They're injected as a depot because you want them to sit there and allow the other immune cells that notice them to get there and find them. If you injected them in the bloodstream, they'd go away very quickly. How often are they given? Well, that varies somewhat depending on what the vaccine is, but generally speaking, it's on the order of 2 to 4 weeks. How long does it take to receive this? This can vary somewhat as well, but again, it's just a shot, so that, generally speaking, doesn't take too long. Often it needs to be prepared, so there is some time on the back end. It might need to be thawed. That might take an extra half hour or an hour, but generally speaking, these treatments are relatively quick. Do any medicines have to be taken before or after? Well, generally no. It's an injection, so sometimes that hurts a little bit, so you could take some Tylenol or a compress around that area. And are there contraindications to getting medicines? Well, not particularly, except that you want to make sure that you're not actually allergic to anything that they're going to inject you with, right? So they always ask you when you get your flu shot, are you allergic to eggs, et cetera? You would want to make sure you're not already allergic to what they're going to inject you with. And are there any drug interactions or medicines you shouldn't take along with it? And again, in general, no, but we're trying to mount an immune response. So if you're on heavy doses of drugs that suppress the immune system, that doesn't really make sense. So you wouldn't really want to be taking those. And how many doses would you take, and how long do you need to take it? This varies quite a bit, and in different settings you may take it open-ended, but in a lot of cases you may take a certain number of doses before they're going to try to attempt and see whether or not it's working. So the next form of immunotherapy we're going to discuss are cytokines, and I think for patients this might be the form of immunotherapy that's sort of the least practical in understanding. Cytokines are very small proteins that are important to the signaling, or in other words, the immune cells talking to each other, getting activated, and moving around in your body. They have multiple categories, and again, this is for your knowledge base. You don't have to memorize all this, but they can be called chemokines or interferons, interleukins, lymphokines, or tumor necrosis factor. This is a diagram of an inflammatory response, and you can see there's a lot of different kinds of cytokines. And they play various roles in the immune systems. All these ILs are interleukins. You can see down here, this is tumor necrosis factor and an interferon gamma. Again, you don't have to memorize it, but just to understand there are a lot of different of these molecules that float around in your body naturally. They interact with specific receptors on immune cells, and they tell the cell how to be active or not active. And one that's famous in the immunotherapy community is interleukin-2, which interacts with the IL-2 receptor and tells T cells to proliferate or to grow. So what are the mechanisms of immunotherapy here? How do cytokines work? Well, IL-2 gets secreted and taken up by other T cells, which causes them to get activate and proliferate and try to, we hope, go after cancer cells. Interferons, which were discussed a little bit earlier, are part of the natural response to viruses. And again, if you inject them, the idea is they agitate the immune system to try to notice things and go after cancer. And this was a little premature. You got too big too fast. But the point is supposed to be you give these and it ramps up the immune response to go after the cancer. But it's somewhat nonspecific because these aren't specific to a certain kind of cancer molecule. So how are these treatments given? Well, so these can be given as injections. So interferon is commonly given as a depot injection. But other treatments are given as intravenous therapies. So interleukin-2 is a treatment that's given IV and therefore given in the hospital. How often are they given? Again, this varies on which one. It can be every couple of days if you're doing the skin injection. But if you're doing one of the IV therapies, this can actually require inpatient hospitalization. So patients who are undergoing melanoma therapy sometimes get IL-2, and they have to be admitted to the hospital for a week at a time. How long does it take to receive them? Again, obviously, if you're getting a shot, that's going to be a lot different than if you're getting an IV therapy, and it's specific to which kind of cytokine that you're getting. And are there any medications that you could take before or after? Again, not particularly. If you're getting an injection, again, it might hurt a little bit. If you're getting one of the cytokines sometimes that's intravenous, sometimes the side effects can be severe, and there are a lot of medicines that can be given, but that'll be under the care of a doctor. Are there any contraindications for taking these? Well, not exactly, but cytokines can be very difficult on the normal system. So cytokines are very tightly regulated under normal conditions in your body, and if you give really high doses of them, that obviously puts things in flux in different ways than they're really supposed to be, and you have to be very careful because they can induce a lot of different problems, heart problems or lung problems or psychiatric problems, and if you have any of these that are severe beforehand, cytokine treatment might not be the best for you. And are there any drug interactions or medicines I shouldn't take along with it? Again, not particularly, but again, I'm trying to activate the immune system, so don't take drugs that would block the immune system. And how many doses and for how long? Well, that depends. For melanoma, if you take interferon treatment, that treatment is often given for a year if possible. Interleukin-2 therapy is usually given in the hospital for a week at a time, and that treatment's given every 12 hours, and a doctor sees how well the patient tolerates the treatment and whether or not it's working, and whether or not to give more doses. So a third category of immune drugs are monoclonal antibodies, and I'm going to discuss them in two flavors. One are non-checkpoint inhibitors, and the other obviously are checkpoint inhibitors. So what are these treatments? Well, antibodies are immunoglobulin proteins that are used by the immune system to identify and neutralize foreign objects, okay? And you've seen antibody structure previously. But the important thing to take home, it sort of looks like a Y. The antigen finding or binding sites are at the edge out here. And so these can basically use like traps, infuse them into the body, and they can basically connect onto things. And that can induce other immune cells to attack whatever that is, or for that, whatever it connects to actually get cleared out of the body. Antibodies, therefore, can be engineered to recognize and bind to cancer-related molecules. And so here's a pretty picture of a blood vessel with antibodies that are picking up blood vessel growth factors. So there's a drug called bevacizumab that's approved for a number of different cancers in which an antibody, the drug is an antibody that's infused, that binds to a molecule called vascular endothelial growth factor A. And that vascular endothelial growth factor A, or VEGF-A, causes blood vessels to grow. And by giving the drug, you're basically depriving the blood vessels from their growth factor, and therefore the blood vessels shrink. Antibodies can also be used as delivery systems. And so using sort of some advanced immunological and engineering technology, you can make antibodies do different things, like connect a cytokine to an antibody. So it goes and sticks to something and brings the cytokine there. You can also hook on another drug. So in breast cancer, there's a drug now called TDM1, in which a chemotherapy is hooked to an antibody. The antibody then goes and finds the cancer cell and brings a very high dose of chemotherapy right to it. You can also connect on a toxin, and you can also cause it to link up to a T cell, and this was mentioned a little bit earlier with engineered T cells. You can have T cells that already have these things put on them, so when they float around, they connect to whatever they're supposed to find, and then the T cell's right there and already knows to kill the cancer. So how are these drugs given? These are intravenous drugs. Again, these are proteins, so just like a hamburger protein. If you put them in your stomach, it probably wouldn't work too well. Well, I don't know if anybody's ever actually tried that, but I don't think it would work. How often are they given? Usually given every 2 or 3 weeks. How long does it take to receive? Well, this sometimes takes a little bit longer. So often these need to be thawed by the pharmacy, and there can be a wait time in administering them. So after you see your doctor, you need to go and check in. They then start the process of thawing the drug. That can take up to like an hour sometimes, and then administer the drug, and that can take about another hour. So I usually tell my patients it takes about half the day. Do any medicines have to be given before or after? Generally speaking, no. If while they're infusing it, you have a reaction to the infusion, then obviously some drugs might be given, like Benadryl or other supportive medications. Are there contraindications to taking this? Well, that can depend somewhat on which drug that they're giving. Obviously, it depends on what you're trying to do. If you have, so if you're someone who has heart problems and then you take a drug that's going to affect your blood vessels, that potentially could be an issue. Similarly, if you have skin problems and you're taking one of these that attacks skin molecules, you may have an issue there, and that just needs to be considered before you start on the treatment. Are there any drug interactions or medicines you shouldn't take? Generally speaking, no, but this may be specific to the particular kind of drug, and your doctor can talk to you more about that. And how many doses and for how long do you need to take it? These treatments are generally given continuously because what they're doing is generally binding to things that are naturally in your body or associated with the cancer. So if you take them away, those things will come back. So those blood vessel treatments are usually given for a time period to see if they're working, and if they are, they're usually continued. What about the checkpoint blocking antibodies? So the previous antibodies I talked about are infused, they go and find and stick, and then other things happen. These antibodies are slightly different in that these checkpoint antibodies are regulators of the extent of the immune response. And they were discussed previously sort of like gas and brake pedals in a car. I sometimes tell my patients they're sort of like the switches in an airplane. Some of them are up, some are down to take off, and some are up, some are down to come back down. They're mostly expressed on the cell surface because that makes sense because the antibodies are relatively large proteins. They don't usually go in the cell, so they have to see things on the edge of the cell. And this is a figure that shows expression of a cartoon that shows expression of PD-L1 and ligation of the PD-1 receptor. And you can see that it's on the edge of the cell. This is the cancer-fighting cell. This is a tumor cell. Expresses PD-L1 and can ligate the PD-1 receptor. You'll notice that PD-L1 is expressed actually in a number of other places as well. These are all other immune system molecules. So PD-L1 is not specific to the cancer, but the cancer sort of steals it as a way to hide from the immune system. Blocking these immune regulators, or these switches, though, can sort of titrate the degree of your immune response. So go from no response to response. And that's sort of figured here. This is an immune cell. This is an immune cell interacting with an antigen-presenting cell, or a dendritic cell usually, getting activated. But after it's activated, it expresses this molecule called CTLA-4, which the drug ipilimumab then blocks, allowing the cell to stay active. So these are the current immune checkpoint blocking drugs that are in development. The first of these that was described was ipilimumab, anti-CTLA-4, and that's approved for melanoma. There's another anti-CTLA-4 drug that's been in development called tremelimumab that you might hear about as well. For anti-PD-1 antibodies, the two that are furthest along in development are pembrolizumab, which is now approved for melanoma, as well as nivolumab. Both of these drugs are being looked at in a number of different kinds of cancers, as was alluded to before. And there are also molecules that are designed against the PD-L1. And those don't have names yet, but if you're sort of in our field, you just roll these off the tongue. MPDL3280A and MEDI4736. This was also alluded to a little bit earlier. There are a lot of these switches in the immune system. So we've talked about CTLA-4 with ipilimumab and PD-1 with pembrolizumab and nivolumab. These are inhibitory antibodies. They turn off things in the immune system. So the off switch is off, therefore the immune system is on. But there are more of these inhibiting antibodies, and it was discussed that these are in development as well. There are also activating molecules, however. And some of these are also the targets for drug development. They aren't as far along, and we don't know as well how to use them yet, but it's very exciting that these exist as well. And you can just see the potential here. So combine one from the left and one from the right, or two from the right, or two from the left. We don't really know the answer yet, and that's what research is going to be about in the future. So how are these antibodies, these non-checkpoint antibodies, these checkpoint, this should say checkpoint, I'm sorry. How are they given? Well, very similar to the non-checkpoint antibodies. They're given intravenously, usually every 2 to 3 weeks. How long does it take? Again, similarly, you got to come in, park, see the nurse, see the doctor, get the drug thawed, then get the drug in clinic. So that's going to take most of a half a day at least. Do the medicines have to be taken, do any have to be taken before or after? Well, again, if you have a reaction, they'll give you appropriate medicines, but you don't need to particularly worry about it ahead of time. Are there contraindications to these medicines? Again, if someone already has an overactivated immune system, so they have a problem with autoimmunity, such as inflammatory bowel disease or Crohn's disease, then we really have to be very careful about using these molecules. It's not an absolute contraindication, but it needs to be very closely considered with your doctor. And are there any drug interactions with these medicines that you have to worry about? Well, with these drugs, we need to be very careful about immunosuppression. So these drugs have to activate immune cells. If there are immune dampening drugs on board, then we presume they're not really going to work. And how many doses and for how long do you need to take it? Well, this varies. Ipilimumab is given as 4 doses, but some of the other drugs are given as an open-ended treatment. And so this varies somewhat by each drug. So I'm going to sort of leave you with this, just to sort of emphasize how complicated really all this is becoming, and you're starting to learn a lot about how the immune system is working. So there are a lot of factors that can dampen the immune response. There are cytokines that are bad for the immune response. There are molecules in the tumor which can shut down the T cells even when they get there. There are other normal immune modulating cytokines that your own cells can secrete to shut down your tumor-fighting immune cells. There are also these inhibitory checkpoints we've talked about, and there are all these activating checkpoints. And all of these up here are potential targets for immunotherapeutic drug development and combination approaches in the future. So to summarize, there are multiple kinds of immunotherapy, and they vary in why and how they're given. Immunotherapy is becoming an essential part of the treatment for many cancers, as we heard about already. And the future is likely to include combinations of immunotherapies and possibly combinations with other treatments, which we'll talk about later today. And it's really an exciting time in the field. And I really appreciate all of you coming out today to hear about it. Thank you very much.